Good afternoon, ladies and gentlemen. Today, I would like to present insulin therapy in the management of diabetes mellitus with a COVID-19 patient. 61 years old gentleman was admitted with the problem of confirmed COVID-19 pneumonia and line hypertension. Initially, he presented with fever, cough, sore throat, and dyspnea on exertion for 2 days. He has no histories of the type 2 diabetes mellitus, ischemic heart disease, stroke, renal, and liver disease. On examination, temperature was under 100 degree Fahrenheit, blood pressure 110 over 60 and 70 millimeter mercury, pulse rate under 100 per minute, and respiratory rate 30 per minute, and saturation was under 5% with 15 liters of the oxygen. Chest X-ray and then it revealed the bilateral lower zone pulmonary infiltrate. According to his investigation, apart from the leukocytosis, all the parameters about the renal, liver, and the serum electrolytes are normal. He was treated with the high dose oxygen therapy, IV dexamethasone, meropenem, CS2, remdesivir, and para and losartan, and other supported measures. On the day of the IV dexamethasone therapy, his RBS was high up to 432 mg per deciliter, so he was treated with the SC atropine insulin 8 units dead and SC insulin morning 12 and evening 10 unit. Insulin dose was titrated according to his blood sugar level, and his blood sugar level was stable with SC insulin at morning 14 and evening 12 units. His HbA1c was 7.4, so his problem was the undiagnosed type 2 diabetes mellitus, reviewed by the IV dexamethasone therapy with COVID-19 infection. COVID-19 caused by the novel coronavirus and now then it became a global catastrophe. Data from the early months of 2020 suggests and COVID-19 and most of the COVID-19 patients have comorbidities and such as diabetes, cardiovascular disease, and hypertension. There is a significant association with worse outcomes and those with comorbidities. Report from the CDC and other health center and show the risk of fatal outcome of the COVID-19 is up to 50% higher in patients with the diabetes and than in those who do not have diabetes. People with all forms of diabetes are increasingly at risk of infection because of defect in the innate and cell-mediated immunity. An acute hyperglycemia and upregulate the ACE2 expression on the cells and which might facilitate virus cell entry. Expression of the ACE2 on the pancreatic beta cell and it can also cause insulin deficiency and causing frequent causes of the severe diabetic ketoacidosis. TPP4 was identified as the functional receptor for human coronavirus. It plays a major role in the glucose and insulin metabolism, but also increased inflammation in the type 2 diabetes. So the use of DPP4 inhibitor could reduce the DPP4 concentration and could provide therapeutic opportunities for the treatment of COVID-19. This slide shows the glycemic management of type 1 diabetes in emergency department. Never stop with insulin, and if the patient RBS more than 250 mg per deciliter, and we should check a urine ketone or blood ketone. And according to the result, urine ketone less than 2 plus or blood ketone is between 1.5 to 3 millimole per liter, and we should give 10% up to daily dose as a short-acting insulin instead, and 1 liter of the 0.9% NS over 1 hour, increase basal insulin up to 10 to 20%, and reassess after 2 hours and treat accordingly. If the urine ketone more than or equal to 2 plus or blood ketone more than 3 millimole per liter, we should treat as an DKA. This slide shows the glycemic management of PUI cases and with a known type 2 diabetes or unknown etiology and the isolation mode. If a patient RBS less than 350 milligram per deciliter, and we can use an basal insulin plus OAD and a preferred TPP4 inhibitor, and we can add sulfonylurea if a patient blood glucose is not controlled. If then a patient has an RBS is more than or equal to 350 milligram per deciliter, we can treat as a basal bolus and previous twice daily is a regime is the alternative. If the patient is critically ill, then we should use a variable rate insulin infusion or basal with an coercion regime. This slide shows the glycemic management of the COVID-19 and the confirmed cases in the designated hospital. My COVID-19 and the cases and it can be and again and continue the original regime if an blood glucose is in target range, and if a patient blood glucose is not controlled, and we can use an base plus OAD, prefer to be before and a better, or and we can also add sulfonylurea and if not reach and a blood and a target and blood glucose in a moderate COVID-19 cases cases and we can use a beta bolus and an insulin regime. Previous twice daily is the alternative form. And we can in severe cases of the COVID-19 and infection refer to the management of hyperglycemia in patients with COVID-19 in ICU setting. This slide shows the insulin regime in non-NCS setting. And if patient is on regular meal, we can use an beta plus OAD or twice daily premix or beta bolus insulin regime. If an patient is on continuous intra or parenteral nutrition, we can use beta insulin with the correction regime. If patient is on bolus enteral nutrition, then we can use beta bolus regime. If patient is critically A and is on nothing by mouth, and we can use an variable rate insulin infusion or beta insulin with correction regime. This slide shows the blood glucose monitoring and then a monitoring in a patient with the COVID-19 infection. Target blood glucose is some 1.8 to 10 millimole per liter, 140 to 180 milligram per deciliter. This slide shows the management of hyperglycemia in patient with COVID-19 in ICU setting. And check blood glucose in all patients on ICU admission, and if RVS is more than 11.1 millimole per liter, and we should check black or urine ketone, electrolyte, and arterial blood gas. And the results show the features of the diabetes emergency. Treat as an diabetes emergency accordingly. And if the result didn't show the features of the diabetes emergency, and a patient should be treated as an uncontrolled hyperglycemia in ICU setting. Variable rate insulin infusion is the most preferred method in ICU and in the management of uncontrolled hyperglycemia. And a subcutaneous beta and a beta correction regime is the alternative form, and all the oral hypoglycemic agent must be stopped, and beta insulin can be continued. And if the more than or equal to 2 consecutive blood glucose is more than or equal to 10 millimole per liter 2 hours apart, we should initiate insulin therapy. This is the target and a blood glucose range and a confirmed COVID-19 in a patient according to the severity of the COVID-19 infection. Recovery trial found that the dexamethasone 6 milligram once per day for 10 days reduced death by 1/3 in the ventilated patient and 1/5 in other patients receiving oxygen therapy. So high dose of glucocorticoid exacerbated hyperglycemia in patients with diabetes and may unmarks the undiagnosed diabetes, and in those at risk of diabetes may precipitate hyperglycemia and new onset diabetes. Steroids are the common cause of the people with diabetes developing potentially life-threatening situation in hospital. Cytokine storm is associated with significant insulin resistance and reduced insulin production from the pancreatic beta cell. And then this pathology can precipitate severe hyperglycemia, life-threatening ketoacidosis, and hyperglycemic hyperosmolar state in people with diabetes, and even in the patient without diabetes. Diabetes UK 2020 recommend NPH insulin, then insulin as then a prefer insulin and for the metabolic effect of the dexamethasone. NPH insulin and then allows more flexibility in dose adjustment. And studying dose was based on weight and reduced dose, and it should be used in elderly and those with EGFR less than 30 ml per minute. If the patient is already on long-acting insulin, and we should increase the dose by 20%, and at 20%, and insulin resistant will fall when the dexamethasone is stopped. So, glucose monitoring and dose adjustment is needed, and to avoid hypoglycemia. Close initial follow-up is advised, and for those with known diabetes, and yearly HbA1c measurement is recommended for those with a steroid-induced hyperglycemia. This slide shows the management of blood glucose in people with or without diabetes, and then with the dexamethasone therapy in COVID-19 patient. This slide shows the management of desabitazone-related hyperglycemia. If an patient is on intermediate or not on intermediate or long-acting insulin, and we can treat the desabitazone-related hyperglycemia with NPH insulin, and totally do a dose and a zero point 0.3 units and a per kg per day, do that in the morning and one that in the and then one that in the early evening. If an patient is on a long-acting insulin or beta bolus, we can increase long-acting beta insulin or NPH insulin by 20%. If patient is on twice daily previous insulin, and we can increase the morning dose by 20%. This slide shows the dose adjustment for the non-acting insulin. This slide shows the dose adjustment for twice daily NPH insulin or premix insulin. This slide shows the aggression dose for the rapid-acting insulin. After end of the dexamethasone therapy, you're gonna continue to monitor glucose 6 hourly and down titrate the insulin doses according to the blood glucose. If when an patient is in more than 70 years of age and his creatinine is more than 175 micromole per liter and EGFR less than 30 ml per minute, and we should use reduce NPH insulin doses. Caution doses are conservative doses and depending on responding individual patients and may need to be increased rapidly. These are my references. Thank you for your kind attention.